are doing. And so I think that my talk, although I could spend hours on many facets of it, I'm only going to 45 minutes, and you'll give me a wave. Will we adjust, or do you still want me to end it at when would you like me to end? Are we about the right time?
Yes, I think 45 minutes from now will be 3:30, and that will leave a few minutes.
Great.
The end time was between 3:30 and 4.
Then that's fine. And also the academic model, some of you know, is also to jump in and ask questions. Differences of opinion, of which I hope we have. We'll save those for later, but clarifications asked. You'll also find it's sort of far-ranging. Some of you know me, some know me well, some don't know me at all, but I'm a longtime professor at the Public Health School, the so-called Bloomberg School of Public Health. And as a tenured professor, I speak the truth, sometimes getting in trouble, but I'm a firm believer in population health, even though my office looks outside to the Sheikh Zayed Tower and the Bloomberg Tower, the most expensive hospital built in America today, and God bless them if we need them. But out my other window is East Baltimore. Most of you know what East Baltimore looks like. So I think that trying to shift the best that we have in Maryland, and Johns Hopkins University of Maryland, dozens of other great hospitals, with the worst challenge and how we put that together. And I think that measurement is key. You know, don't measure, you can't manage. I think focusing on hospital care episodes. My colleagues, the story I always tell my students is, you know, the most wonderful woman I've ever met, aside from my wife, who's not listening, I don't think, was a NICU OB doc at Hopkins. You know, who, if we ever needed someone like her for our family, we would really want her. And yet, every time I brought my public health students to talk about the challenges of East Baltimore and you know, babies that were dying that shouldn't, she says, yeah, I'd like to help, but that's just not how I'm structured. But then Medicaid, I think, set some both HEDIS metrics and of course moving to capitation. This goes back to the health choice. And all of a sudden, who is now out in the community trying to ensure? So I do believe that context, that global approaches, and community is everything. So that said, let me move more quickly than I've done so far. And my goal for today is to talk about certain trends. I think some of you could give parts of this talk, but I have been focusing. In fact, although I'm a public healthcare person, so-called expert on managed care, whatever that is, also I've spent most of my career doing measurement metrics, usually with digital sources. Some of you might have heard of the ACGs, which are used by Maryland and 25 other Medicaid programs, or a case mix approach. I've also was among the first, before CMS did it, using claims data to measure quality. You know, of course, they're meant to pay bills. They do that, sort of. And but now I've been bitten by the bug, and I'm somewhat evangelical, for a nice Jewish boy, but still evangelical, that all of us, particularly everyone in this room, must understand what's coming down the pike with the electronic medical record, electronic health record, EMR. You know, the meaningful use program, which most doctors and the hospital administrators aren't so keen on, but you know, it's put what, $30, $40 billion out the door, and it's worked. So this slide here, and I also realize there are people at home, so you can download the presentation. But we forget now that about 80 to 90% of all the docs now have an EMR on her or his desk. Now, granted, they're not all meaningfully using it. In fact, most of them are not, but they will. They will. The young medical students at Hopkins will have it no other way. And so one of the messages here today is that, you know, maybe not the first year or two that the program rolls out, maybe not even year 5, but for sure, if this becomes a new program in the future, it can't be based on legacy HIT systems, health IT systems. So that's one of the messages. So I will talk today in my 43 minutes about sort of the evolving, what we'll call it e-health or health IT or EMR digital milieu. Healthcare is probably the last bastion of non-digitalization in society. You know, things that we do in very many other places. And it's amazing, you know, all the medical students, all the public health students, all the nursing students, everything they want to do is whether it's mobile health, M-Health, or electronic medical records, or apps. And it will change, and most of us established people don't appreciate that. And so those of us in measurement, those of us in management, need to take that into consideration. New paradigms, new ways of doing business in measurement. And you have opportunities, you know, as you, most of the measures that are being used are decent measures. They've been in place 10, 20 years. That's fine. That's important. But we need to think about the future as well. As a professor of public health with Johns Hopkins Hospital on one eye, and then the other side across from my office is also the East Baltimore side of the Baltimore City Health Department. Every day I see the two juxtaposed. God bless any of you that work for the city health department, but the only way we're going, or state health department, but the only way that we're really going to move toward population health is through what you guys are doing. Taking the finances, taking the strongest infrastructure we have in the state, which is the hospital system, all due respect to the public health infrastructure, and flipping it around to what matters. Not that, yeah, sure, that NICU neonatologist friend of mine is great, but the babies, 80% of them shouldn't be there. Yes, God forbid we need the ICU at Maryland or shock trauma or Johns Hopkins, but you tell me, but 50%, 60%, 70% of people shouldn't be there, whatever the number is. And that's what flipping the system on its head is about. You cannot do it without health IT. Impossible. Absolutely not. And that goes beyond measurement. I know that there's some data infrastructure people here. I know most of you in your day jobs don't view yourself as a measurement person. In fact, I probably spend more time on measurement than many of you. You guys are leaders in management, and finance, and in IT, and other things. But population health can't be done. And then we have, because it's so important, we've actually met with Josh Sharfstein and his team, and with Donna and others, but a group of us, not just me. I and Albert Wu, who's actually on this committee, and she's online here. I will pause, and Albert can say a few words. But 10 other of our colleagues actually came to meet with leadership at the state and the HSCRC to find out ways that we could help. And I know that the CMS is very interested in what you guys are doing, not just because they sort of have a lot of the cards, but because I think they really hope you succeed, because then others can follow. And even I've been talking to a lot of reporters and others, even people around the world. So it's up to us, Hopkins. We do local, we do regional, we do global, as you know. And so part of it is really to try to help you succeed. And I know you've all seen professors from Hopkins or doctors from Hopkins. We're from Hopkins. We're here to help, and it's not that kind of help. It's really to find out, the niche that you might need us for, not to reinvent any wheel, not to be know-it-alls, whatever, but to really some of the new development. And so that's a lot to do in 39 minutes. So let's move quickly. So this is all online. Most of the things have sources and URLs. This is a presentation that I developed that I've been using just to remind everybody. I don't know where to point, so I won't point. But if you look at the two concentric circles on the with the doctor and patient at the center, or it could be nurse or other clinician and patient at the center. Our healthcare system is very clinically oriented. That's fine. But even the sickest person, not just someone who has a cold, but someone with 8 chronic conditions, only spends what 0.5% of their year with their doctors and nurses or hospitals. Even if they're really sick, the rest of the time they're with their families and with their networks and with their community. And that's sort of what the essence of population health is. So if you think about on the right-hand side, the patient, classic patient, but the family and the community, the population health aspect is really the right-hand side. On the left-hand side, if you think about the healthcare system, the idea of the 20-minute visit is sort of archaic. The idea of the individual doctor is archaic. Whether or not it's the PCMH or the accountable, patient-centered medical home, or the which of course is where, although we're not talking about PCMH or the SIM project, I think everyone in the room appreciates that if any of us were the czar of global health reform, it would not just be hospital. It would include both the SIM and the all-payer, and that's certainly my mindset. Some of that's beyond people in this room, but I just wanted to get that out. But clearly it's not just about hospitals, but it's about integrated delivery systems. And I smile broadly when I see my own quaternary care system, Johns Hopkins, and many of you moving away from, and a lot of it was in the rural pilots, moving away from inside the wall of the hospital to all providers in the community, and not just even medical providers. And so that's again what the IDS, Integrated Delivery System, or ACO, and I've been privileged to work, and none of them are perfect, hardly, but with some of the better organizations of that type, Kaiser Permanente and Geisinger and the British and Swedes and Israelis. And although they're not perfect, we have a long way to go. And that's, I have not seen anyone closer in the country than you guys in trying to move to that direction. So that's what the two blue circles are. But let's just go real quickly around the rim there. And so we've got, and I can share the article, we have the electronic health record. And of course, an EMR is not just EMR. It's also about clinical decision support. In the future, doctors and nurses will use the human side of their brain, not the technical side of the brain, because that computer will always be smarter than any of us in the room. I don't think it'll be more humane, not for a while anyways. And so the whole clinical decision support, there is no excuse for any clinician in America to do something stupid when science knows that it should not be done. Of course, 90% of the time, EMRs aren't useful for that. But one day that will happen. POE, provider order entry. I think that all of us have ordered the wrong color on Amazon. I know I have once or twice. Mm-hmm. Any of you clinicians, if you click on the wrong drug, you can kill somebody. But one day, virtually all interaction between the clinician, I shouldn't say virtually all, but a lot of the interaction will be through the provider order entry, e-prescribing. What is it, 90% of all the doctors in America today e-prescribe? 5 years ago, it was 10%. It's just utterly amazing what's happened. And that, too, by the way, those are metrics. You now know when a doctor orders a drug and when the patient gets the drug and whether or not it's the right drug. I don't think I saw those kind of things in the metric that you're considering. Today, that's available. The NQF and ARC, et cetera, haven't really thought about those because they weren't available 3 years ago. I've been working with health departments and working with social services agencies. There's really no excuse for public health and hospitals and human service agencies all have separate information systems. They all should be. Mayor Bloomberg, I wish I had $50 million every time I had a good idea. He wrote $50 million check to his health department and his human resources department, and they share in New York City before he left the mayor all of their data systems. No, we can't do that. You can't do that. We can't do that together tomorrow, but build it and they will come. So I encourage you, and I know you've thought about that, to find whether or not it's Montgomery County or a few of the leading health departments actually have started linking their social services data. And you should, I'm sure you thought about it, but actually start developing metrics that are linked between not just public health, but also non-medical. And biometrics. And increasingly, for $5, you can buy an undershirt that measures your EKG if you'd want to do that, or your blood pressure and your heart rate. But for elderly, that's not trivial. And I think one day it will be possible. We all have cell phones. They have accelerometers. It will be possible to actually to measure how much exercise people in the community are getting. I can go on, but I won't. And just to give you a flavor of, it's not just about certainly the claims or the EMR. And the Accountable Care Organization, as you know, is a virtual organization. And it's really held together through the HIT. And pardon me while I cough. Apologize. So the claims data, the next two slides is just to remind you. Today in America, thanks to the ACA, Obamacare, almost everybody now is their healthcare interaction is captured through the claim, through the administrative record. Most of you probably know or don't know, depending what side of the hospital or the business you're on, that through electronic data interchange, that financial information happens almost instantaneously. The EDI, electronic data interchange, but it's going to change. What is the first or second thing any boss does, a hospital CIO does when she puts in a new system? He uses it. In our case, it's a she. Uses it for financial purposes. Will you be running claims data and administrative data separate from the clinical data? No, you won't. Do people do it now? Yes, they do. That's because most EMRs are just really baby systems right now. Only 5% of the EMRs in Maryland are really fully functional. That will not be true, whatever the number is. It's not the majority. In the near future, it will be 90% or 100%. So what I wanted to suggest to you is right now we're at sort of nearing the peak, thanks to the ACA, of data that you can use for performance metrics, and that's great. But as you'll see from, this is an estimate, but an educated estimate. In the future, the red will go down and the blue will go up. And I think build it and they will come. I'm not going to go over this slide, but this goes through the pros and cons. Those of you that are clinicians in the room understand the weaknesses for performance metrics of using administrative data. But the strength of the EMR is that it has clinical information. So again, I would encourage you to think about these new data sources. And also, when you think about the community sources, there are, whether or not it's a personal health record, whether or not it's these health apps, whether or not it's, people right now talk about surveys as the main source. I saw you have all kinds of CAP surveys and all types, and that's fine. That's it's only the people that complete it. It's only those folks that are contacted. But there are all kinds of sources of information, from consumer digital capture, and that's again something to look at in the future. For example, if you have a Giant card or a Safeway card, they know everything you bought at the supermarket. And again, it's a little scary, Big Brother, but there are, or it can even be done on a community basis without any of us fessing up to those potato chips. But there are all kinds of sources to capture health information that are really available now. I'm going to move fairly quickly because I want to leave time for discussion. To be honest, but I jumped at the opportunity when Diane invited me, although the scheduling is a little tricky, doing a lot of traveling. But I grabbed a bunch of slides that I've used before, so I'm going to move through some of them with 2 or 3 exceptions of new slides. I'm going to move them quickly to leave discussion. But the next series of slides, I've been doing work with the National Quality Forum and the National Committee on Quality Assurance, NCQA, ARC, and others. Just like I and my team were among the first to use claims data for non-financial purposes, again, for case mix, for quality, et cetera. We're now, and we're still in the early stages, trying to use EMR, EHR for those purposes. So I'm just going to remind you in the next 5 minutes of some of the new paradigms, the new ways of thinking. I know we have some data people here, we have some clinical people here. For some of you, this is new. But just to remind you that when one talks about using health information technology, or HIT, there's really multiple kinds of purposes. One is sort of internally, real-time safety. No, don't order that drug. Or no, that lab test just hit a level where the patient is at risk of dying. We better have the iPhone or Android beep on the nurse's waist, because if someone doesn't respond quickly, that patient is in trouble. That's probably not what this group is going to focus on, unless it's monitoring how well a hospital starts using those things. By the way, most of the meaningful use, which I'll get to in a moment, is really about, for those of you that studied quality, you know about structure, process, outcome. Structure is making sure the hospital doesn't burn down. Process is making, or there's an autoclave or whatever, that the physical facility looks good. Process is making sure we do the right thing. And by the way, only half of what doctors and nurses do are based on evidence. So doing the right thing doesn't always work because we don't know. Plus, even sometimes you do the right thing, bad things happen. And then the last is outcomes, end results. Would that everything could be end results. Right now, in the meaningful use, we're really more on the structure, just making sure that the doctors, nurses, and hospitals put a system in place. So I would encourage actually that some of your metrics, and I think you're considering that, actually be structural. And I'm suggesting to you in the health IT domain, that's probably going to have to happen for a while. But for example, does the system have a way of knowing when a lab test comes in that shows that the patient is in trouble, and does the PCP get that within an hour or 30 minutes? There's no excuse that it doesn't ring on her iPhone nowadays. So that would be an example. That will happen with 100% certainty one day. It's not happening now in most cases. So that's an example of how this can be used for real-time safety. Most of you know about retrospective, looking after the fact, how often that happened, and that's good. I also want to suggest to you that, and that's sort of the classic medical model. And again, much of what is still that we're talking about is the classic medical model. It's the community where we're all trying to come up with new answers. And again, the shift that you guys have done is fantastic. I think the more it can move toward non-medical, the better, and I think you've tried to do that. But I think together we all need to think about all of the people who aren't engaged in the healthcare system, and by having the hospitals and doctors and nurses, helping to support good health. Easier said than done, but I think that will be key. You can't begin to do that without health IT. You cannot begin to do that without thinking about the denominator of patients and the denominator of the community. So that is, again, I know I'll keep saying that over and over again. And in candor, I would say only a very small percentage of the actual metrics, that you're able to do today do that. They tend to be more ambulatory. They tend to be more prevention. That's good. But I think together we should try to identify some new sources, whether or not it's using public health data, whether or not it's using social welfare data. So that's one of the activities. I'm going to jump ahead. This is an overview just to remind you of some of the metrics that I've already mentioned: process, structure, and outcome. Actually, it talks about process and outcome, but also patient-centered and cost, and the denominator. One of the problems with most hospitals in Maryland, and one of the Achilles heels, which I know you're trying to grapple with, of the all-payer, is what is the denominator? Is it the community? Out of my window, if I go on the roof, I can see Mercy, I can see Hopkins, can't quite see Bayview, but who's patients don't always go to a specific geographic area, and what is a community? What is a patient? What is a consumer? And so the denominator is really all important, and how we capture that is easier said than done. I think I've already touched on these new electronic sources, that is the provider order entry, that's e-prescribing. The personal health record. Most of you, if you get your health care from the big provider, you now can communicate with your doctor and access the EMR, often called a web portal. I don't much like that term, but they let you have access to the EMR. And some countries, and some even think that what will happen in this country, it won't be MedStar that owns the medical record. It will be the patient. And if the patient goes to MedStar or Hopkins or Maryland, the record will go with them. By the way, I have great respect. I haven't mentioned them yet today for what CRISP is doing. They are one of the leaders. I think that they have, they're not doing anywhere near enough. That's not their fault. Hospitals and others are sort of nervous about what they should do with the data. But they are, I think they should be freed to use these data for purposes, because one day it won't be about single health systems. It won't even be about health systems at all. It will be about how the data can be used. And by the way, we have experts in encryption, we have experts in security, we have experts in ethics, we have experts in legal here in Maryland. We need to figure it out. It's not just about the data issues. Obviously, we don't want the data flowing around. But you wouldn't believe what these consumer organizations know about us, without any rules and regulations and ethics oversight. In some cases, it's more than they're in our medical records. So the genie's already out of the bottle. So that's another important point. I know I'm jumping around, but hopefully you get a picture of all these things that are out there. Just real rapidly, I have several articles on this. Today, almost everything that's being done with the EMR is replicating what was done without the electronic medical record. So for example, the NCQA and NQF, and most of the meaningful use is just simply doing what you could have done with paper and what you could have done with claims. That's okay. That's good. I call that sort of legacy or translated measures. There are some things that you can do with an EMR that you could have done with paper. You wouldn't be silly enough to. So I could have looked at our Johns Hopkins Healthcare HMO. We could have looked at all 50,000 people with high blood pressure and find out their systolic and diastolic blood pressure. You wouldn't be silly enough to go to 50,000 records. By the way, in 30 seconds in the future, we will be able to know the blood pressure and the BMI and the latest hemoglobin A1C of everybody in the community. That will happen. Maybe not tomorrow. But Kaiser Permanente is doing it now. They're doing it in Sweden. They're doing it in Israel. We will be able to do it in the not-too-distant future. And many of your health systems are able to do that. So I call that HIT facilitated. The part that really excites me, and this is really going to be more something that you would do on an innovative basis, are things that I mentioned before. Communication, real time. What did the doctor know when? When did she communicate with the patient? She could have used this criteria, this new clinical decision support criteria. Did she use that? The drug was ordered by the doctor in such and such a day. When did the patient pick it up? Were the measures that are supposed to be measured for the Coumadin was that measured? And do we know that instantaneously when the blood level was at a wrong level? This is stuff that is not science fiction. It will happen one day, and frankly, it will then free up the hospital to focus, on other, human part of curing and caring. So again, this is what we call HIT enabled. I know I'm talking about some pretty more advanced things, but there are a lot of activities that the EMR can do. Another important point is for the foreseeable future, the EMR and other health IT systems can cause some damage. We coined the term e-iatrogenesis. Click errors are the biggest right now. That is when you click on the wrong patient or you order the wrong drug. And again, that's something to monitor as well. Those of you, you're not going to talk about it in a public area, but go talk to your CMIO or Chief Nursing Information Officer and talk to her or him in private about some of the close calls that have happened with the new EMR. And that's something to consider as well. Looking at the clock, I want to jump ahead. Just some of you know about this. Most of you probably don't. We at Hopkins 25 years ago, when I say we, I'm talking about mainly the public health school that I'm at. And I am independent. I work and I collaborate with the health system. I'm not part of it. I also collaborate with other health systems too. So I really represent more. Actually, I don't represent the university. I'm an independent professor. But nonetheless, we at Hopkins have developed something called the ACGs, which are used in about 100 million patients around the world, and are a case mix metric. They are used primarily for populations, not hospitals. But that opens up the opportunity for some of your advanced applications. So they're used by Medicaid programs, including ours here in Maryland, which was, I believe, one of the first, or the first, to use risk adjustment. It's used for case finding. We are working with the folks on the SIM side and with some of the Laura and Karen and others on the PCMH and exploring opportunities. But I did want to let you know that widely used, this is, again, you can download it and look at some of our predictive modeling case finding. This is really more population health care management than it is measurement, but since I had the slide here, I thought I would share it. This is measurement. There is a leading integrated system in Minnesota called Health Partners, which, I don't know, a couple million lives. And they developed a tool that was endorsed by the, I downloaded this from their site, it's brand new, from the NQF, where they now develop what they call a total cost of care metric. So one of the challenges is, for your innovation, how do you capture all costs? I don't have the answer. Excuse me. But clearly, the need to understand, great, hospital care may go down, but is specialty outpatient care going up? Or as pharmacy care goes up, does hospital care go down? So how do we monitor everything? So this is, I thought this was pretty neat. I downloaded from the Alliance of Community Health Plans, which is a consortium of sophisticated integrated delivery systems. I can give you the reference, or you can find it pretty easily. This is one of their dashboards, one of their scorecards. I thought was sort of neat. It may not be exactly what you're looking for, but and it used the Health Partners Total Cost of Care Performance Dashboard, and it has a whole bunch of mixed sort of cost and quality metrics. By the way, this is for everything. So it's for 1 million patients and includes all of their services. Will we be able to do this in Maryland? I think one day we will. Is that under your purview? I'm not entirely sure. But if you're talking about population health, this is what you're talking about. You're not just talking about certain types of services are in and certain types of services are out. But this, again, may or may not. I know you have other work groups that are dealing with cost and payment and efficiency. But by the way, this is performance metrics is what we're looking on this slide. I want to move ahead. What am I going to do in the next? I have, what, 15 minutes or so, Diane? 18 and a half. Okay, so I have lately been, again, I'm jumping around, but hopefully some of this is useful to you. But the next part of it, I've been trying to build a new domain, which is sort of a combination of, and again, it's well suited to what you guys are doing, I believe, but you tell me. I call it population health informatics. It's linking three different things. Off to the right in salmon color, which is the public health color. Population health, public health. And by the way, I prefer to use the term population health. I'm a strong, huge supporter of public health. Public health systems in the country control about 2%, 3% of the healthcare dollar. God bless you, all of you who are in public health. But the hospitals and health plans of America control the other 97%. So if we're going to really have an impact on people and consumers themselves, so if we're really going to have an impact on people's population health, it's going to use the $2.5 trillion that we have, $8,000 for man, woman, and child, the most of any system in the world, and that's before we added Obamacare money to it. We've got to do it with these three, in my opinion, concentric circles: medical care, not just public health, and we're foolhardy in the next remainder of the century to do it without health IT or informatics. So hence, we've started a new center at our public health school that we call the Center for Population Health IT, CPHIT, or CFIT. And surprise, surprise, two of our top priorities are metrics, because you can't do the things that we're talking about without measuring it. You can't measure it without health IT. And actually using these tools, which goes beyond metrics, for implementing change. And I won't read this, but you can download it, those of you at home. There is a controversy out there. I use the term population health. Some of the public health people are not happy. In fact, I went and had a meeting at the American Public Health Association. And it's this picture right here. And that is in the Baltimore city. There are however many people, 900,000, 950,000. Some may be part of a health plan, some may not be. Some may be in the Mercy catchment area, some may not be. But unless you look at the whole community, how do you ensure that you don't miss anybody? Yet, your hospital, your accountable care organization, your health plan really only is focusing on the subset. I don't have the answer. But the fact of the matter is, we've got to try to figure out, and that's some of your, I think, charge, is how do we take a combination of these smaller circles and make that into the full community. I do think that with health IT, we now will understand numerators and denominators. We now can have the medical care system, I've been talking about this for the last half an hour, move toward population. And this whole concept of value, by the way, that's a whole other thing we haven't talked about today. But as we go, I haven't talked about genomics. We have a lot of colleagues at Hopkins and at Maryland that are planning for the, as we know more and more about the genome. Right now, I think there are 1,000 things that they can measure out of the billion things that are there. Of those 1,000 things, there's only 17. I'm making this up, but not by much. It's about accurate. 17 things that doctors and nurses can do. Out of those 17 things, most of them cost $500,000 and might get you a few more months or a few more years of life. So this whole domain of value, I'd encourage you to, you don't want to grapple with all of that. You've got enough to grapple with. But somehow, just because something can be done, that doesn't mean it should be done. And nobody wants to address. We're all going to die last time I checked. Hopefully we're going to die a long time from now, or we're going to die well. But the whole issue of palliative care and hospice care and end of life, that's completely tied into this whole thing of value. And so I think that understanding how we maximize the value for the society, including those, I'm joking, but I'm not joking, those are all pretty serious issues, the genomic and the end of life. And I'd encourage you, to the extent you think you can, to try to deal with this. And there's no way you can do it without the whole, broader measurement. Again, I'm jumping around, but let's keep going. So this is, excuse me, I apologize, but I didn't want to not come in today, and I'm not breathing on anybody. So this is a slide that we put together. I know Albert Wu's on the phone. I'm going to call on him in a moment. But the next couple of slides, we had a team, several of us, economists, epidemiologists, some mental health people, and some quality of care people, including my colleague Albert Wu, who's on this committee, I believe. And I being more of a measurement and health IT people. We came and talked to Donna and Josh Sarstein and said, listen, we would like to find a niche where we might assist you. And I'm not sure if you means DHMH, if it means HSCRC, if it means the provider community, probably yes and yes, because it's and obviously without the masters, EMS, and I know that the Innovation Center is very interested in a lot of this. We've also been working with the other commission over there, right? 6 feet away, Healthcare Commission, which does a lot of the health IT stuff and all payer stuff. And also we've been collaborating with Chris. And we're trying to figure out, we, meaning the faculty at Hopkins, not the health system at Hopkins, they like many of you, are wearing the healthcare hat, and that's fine. But as the academic, as the public health development people, how can we help facilitate the process? So the next couple of slides, let me tell you what we have. This is a schematic that we quickly put together. We believe that one day, whether or not it will happen in your next 5-year time period, I'm not sure. It will, with certainty, happen in the next X years. I don't know if X is 10 or 20 or 30 or 40. But all of the data in the state of Maryland and every other state, and I think we're actually going to be one of the 2 or 3 first states that is captured by hospitals, captured by health departments, hopefully, if we do it right, also captured by social service agencies and consumers themselves, can be pulled together. It'll either be done haphazardly or it'll be done well, but can be brought together in an efficient fashion, and this includes the electronic health records and the information exchange, which right now is quite challenging, and the claims. And we coined this term Maryland Population Health Information Network, or M-PHIN. And the other 2 slides, which I'll get to when in a moment, talks about some of the role that we were offering, and this is sort of wearing the academic hat, of things that we might be able to do to fill the niche. I mean, you guys are doing so much, all of the agencies, but there's still, it's an all-hands-on-deck kind of thing. And these are some suggestions. Now, the goal of this meeting today was not to go through the list and get our assignment from you or any other group, but really just to let you know, I know there's some Hopkins affiliations, on this committee, that this is sort of what we had in mind. And this is a good time to pause, and I can take a drink. Albert, if you're still there, I don't know if you I guess you can't see my slides. Can they see them as I move through? It's on the web. Okay. So, Albert, I was on slide 24, which was the picture of all the data system, and then slide 25, which I believe you and I put together to suggest some of the things we might do. So why don't also you have more of a sense of more committee. Of the committee. Go ahead, Albert. Say something about.
Yeah, I've actually managed to unmute myself, which was almost the hardest thing to do. Thanks a lot, Jonathan. I think that you've given the group a sort of a real nice survey of a lot of resources that this work group might at some point or another avail itself of. It's a little bit of a smorgasbord of of tools and maybe some data. I think there's a few things that are sort of really interesting for this group to think about. One is as the state and to some extent the HSCSC, I think that requiring organizations to provide all utilization data and and creating a pool of those data might then allow us to really begin to look at total costs of care, which I think would be very important for the for the state period. And then something that this organization, this work group would be concerned with would be, so, obviously you can save a lot of money by doing nothing. And so part of what we might want to be doing is to monitor the impact and the relationship of that total utilization and shifts in utilization on quality and safety, particularly for some groups that are more likely to be vulnerable. So that's all I have sort of off the top of my head, but I was happy to see your presentation.
Okay, Albert, thank you. You also gave me time to have a cough drop, too. So, again, I apologize, everyone, for my coughing, but we're almost there. So, just really wanted to I know I'm jumping around, but as you can tell, I'm excited about this. I think you have the opportunity. You can't possibly do everything, but with all of the different views that you have, I have no doubt you will develop, as you say, a balanced scorecard of the right things to do. And I'm also very sensitive to the fact you've got to do things that you can do today, but I also encourage you to think about the future, whether or not.
Hey, Jonathan?
Yes.
Sorry, it's Sean Tunis. How you doing?
Hiya, Sean. Would you like to say something at this juncture too?
Well, I had a question for you just about the slide. I think the ones that's up on the, it's the second bullet on the new quality measures, and the last item you listed there was measures of overutilization.
Sounds like a setup,
I've been
John.
wondering.
That's my next two slides.
Oh, okay. Well, then
it
great.
wasn't a setup, though, was it?
Perfect.
So hold on to the next two slides. And I actually, I'm going to, I think Diane wants to spend the next 10 minutes to answer questions. So is there anything else you'd like to say, or is it about the choosing wisely that you had a question? If it's that, hold off for a second.
It's all about, well, not just choosing wisely, but generally the state-of-the-art of overutilization measures. And I just wanted to say you're doing a great job.
Thank you. And it's good to see you, but I can't see you. Good to hear you. All right, so I'm not going to go through all of these, but I would encourage you to look at them. I hope if things go well, I and my colleagues will come back. And I know it's not just this committee. You've got, what, 3, 4, 5 committees, and there's some overlap, which is good. But let's just jump ahead so we can finish off and open for discussion. So the next slide, and it was not a setup, and Sean obviously didn't look ahead, is that I have great colleagues at Hopkins, and 3 or 4 of them have been bitten by the bug, understanding that that overuse is a big issue in our healthcare system, and measuring it fairly and taking into consideration an operational basis is important. They got a small grant from the Robert Wood Johnson Foundation. Dr. Jody Siegel, who's an MD, Dr. Kitty Chan, who's a measurement expert, and Dr. John Bridges, who's an economist, and some others, have started to develop a whole array, claim-based at first, but we're now actually working on EMR-based, of an index, of a scorecard, using the state-of-the-art. And they have, in fact, it's on the easiest URL I could find for you. It's already on your web page. Dr. Siegel submitted a white paper, I guess. And just to let you know that it's there, and I would certainly encourage you, whether or not it's this one or others, they have a metric of, I don't know if it's 100 different conditions. Here's just a few examples of them. They actually have many more than this, but these are things. The choosing wisely, some of you know, is that all of the specialty societies know they're in trouble. They wouldn't have done it if they weren't in trouble. But nonetheless, they're doing it to their credit. Of all of the specialty services that have been ordered for years, mainly because it makes somebody some money and it helps a patient now and then. But by and large, it should be the rule not to do it rather than the rule to do it. And I don't know how many Sean knows better than I when we go back to him. But all of the 20 specialty societies. And this is a metric that actually shows they've done analyses across 400 or 500 catchment areas in the U.S. Hopefully we can do it here in Maryland. And the more people order, the higher the index, the more likely it is people will die, not the opposite. So nobody would say that these things are good for you. So by the way, the natural concern when you tell doctors to do less is, of course, that it could harm the patient. And that's, something you always have to be careful of. So I just wanted to highlight that. To finish up, I think I'm actually more or less on time, even with my wheezing, is that this is a slide that we prepared for Secretary Sharf's team, talking about, at least in our opinion, 2 or 3 on each side of some of the challenges in this case in the measurement and data infrastructure domain. First of all, it will not be easy to move hospitals and hospital administrative systems and management systems have done a phenomenal job of doing what we pay them to do, and that is treat for patients from the time they walk in the door to the time they leave. Now, granted, it's a little more than that, but that's basically what it is. Whether or not it's an outpatient visit or an episode or et cetera, that is not how one would design a payment system, in my humble opinion as a professor of public health. And moving from that to what we're trying to do, whether or not it's episodic or population, will not be easy. I'm telling you things you already know. That's why you'll believe me. So secondly is that to date, most of the measurements, CMS and others, have really been based on these legacy claims administrative systems, and we have the best in the world data systems of that type. Our EMR systems are not the best in the world by a long shot, but our payment data systems are. And so, shifting from that to these new approaches will not be easy. Although the electronic sources that that I'm talking about in touting and evangelizing will happen. It will happen. Trust me. Maybe not like I'm describing, maybe not when I'm saying, but it's not going to be easy. So I don't want to make it sound like taking these EMR systems and using them for all the things that I'm suggesting use them will happen tomorrow. So those are all the negatives, not negatives, but things that we have to, the SWOT, the yin and the yang. The opportunities, and this is, I think, why we're here and why I would give you guys all an award for good government if I could, and I really think it's one of the most important things in healthcare, that I've seen since Medicare has been put in place and since Obamacare was put in place, is the stars really are in alignment. I think that what we do here, Uwe Reinhardt, who's quite a wise guy. I'm a bit of a wise guy, but he's about 10 times more of a wise guy. I don't know if some of you saw it. He said this is the biggest thing. What we're doing, what you're doing, is the biggest thing in healthcare since Medicare. And he didn't even say Obamacare. He said this. So it's somewhere on the web that he was quoted by the Kaiser Family Foundation. So go find that quote. It's a little different, but that's more or less what he said. And so I think that the all-payer, CMS looking over your shoulder, them being 10 miles from here, 5 miles from here, and the all-payer PCMH and Care First. We have a Care First rep here. I think what they're doing is great, although it would be good if they could be on board, and I think they are. Part of this whole system. I know there's always a little again, yin and yang between payers and providers, but I think clearly it has to involve the PCMH and SIM side of things, and it is happening. I think the metrics that you're developing will become a national model, so I encourage you to get it right, and that's why I'm here visiting. I think that some sort of community-wide population health, that is, it isn't just for one hospital or one insurance company like Care First, but a joined up system really can happen here. Not because we're so smart, but because we have to do it. We're smart, but that wouldn't happen without the pressure of the finance. And I think, lastly, I really think that how often, I've been to a lot of states, pretty much all of them, from a healthcare perspective. Even Hawaii, that was the best junket I ever had. But I think there are 2 or 3 other smart states that are as smart as we, and we're not perfect, hardly. But I really have respect for the organizations in this state and represented around the table, and I think we can do it, in part because we have to. But and so I would really encourage you not just to do the minimum, but to do that plus more. And that's why I'm here, and I think that's right on time, and that's a good note to end on. And Dan, I'll leave it to you to also direct me. I know I covered a lot of territory, but hopefully some of this is useful to you, and I also look forward to coming back when I can speak more clearly.
Thank you very much. So I think, are there questions? Discuss. People are speechless. I think there's a lot, and yeah, and all very exciting, as you said. You want to turn it on? Sorry.
When you do come back, I think it would be great to have you look at what we've laid out here, and given what your insight into the future and different things, what you would change, and measures that you would want us to look at. Actually, some recommendations.
Glad to do that. I think obviously, can provide a comment here or there. It's also my hope, in fact, we're coming to talk with Donna next week, and we'll be talking to Secretary Sharfstein about more than that, how with collaboratively and also at your direction, identify certain areas where we might help you and develop stuff. So that's our hope. I'm a man of many agenda, none of them hidden. So one of the agenda is that we can find a way to collaborate. But sure, whatever else happens, I'm happy to look at your list and give you some specific feedback, areas of omission or commission from my perspective anyway.
Yeah, I mean, one of the, I think, looking at our list, what jumps out is, we skipped the IT-related developments, and we did that as questions in our slides. If you are trying to encourage the development, HIT and trying to link them together, are there structural measures that we should be thinking about if that's where we are going to start? I think I'll echo Trisha's point about, thinking about what we have in front of us and trying to move that to the next level, because we really focused on what was available and what our goals were, but I don't think we had enough discussion, or it wasn't part of our agenda in the beginning, to really look beyond it and try to adapt the measures that will lead the system to a place where you are describing.
If I could jump in here to tie some two pieces together, you mentioned adding some structural measures to our scorecard and IT. So maybe for consideration, a structural measure would be the number of hospitals that are meeting meaningful use. And it's something that would also tie to our payment.
I know that number. It's 45.
We might not want to publish that by hospital.
But with all the challenges, half empty, half full, this state has never been more advanced in EMR than it has in this moment. And I think that's pretty phenomenal. And that direction of travel will continue.
To the point of right now, most hospitals may be meeting meaningful use, but as we move into stage 2, and if we get a stage 3, and that bar continues to be more and more difficult to meet, that number may go down, and I think that would be an interesting thing to keep an eye on.
Although the meaningful use, I give them credit at ONC for not just putting computer on doctors' desks, but let's face it, there's all kinds of challenges and issues with that. And so you guys, and it won't be here for so much longer, a couple more years. So I think you guys should think ahead. But the EMR will be in every hospital, on every doctor's desk. So it's okay to think outside the box a little bit.
HIT survey of hospitals in terms of what the status of programs, their EMR, TCOC, those kinds of things. So there may be some information there too.
I'd also encourage you to it's not, yes, the hospital should do it, but really this linkage thing is the challenge. So our doctors communicating with public health, community, are the PCMHs, which are being formed, Care First, and, with both the Medicare and their own side and all payer and the SIM, is that side of the house talking to the hospitals. And just as you know, just simply building that linkage, even if it's just transferring records. And did you know that, you do know that, and my jaw drops when I explain it to my students, because in my 30 years as a professor, it's only been this year that it's happened. When someone is in the emergency department within X minutes, it is now known instantaneously in the digital data system. When someone is admitted or when someone is discharged, it is known immediately. It has never been the case in the state of Maryland, and to the best of my knowledge, Maryland is one of the top 2 or 3 in the country with that data in the data system. Is CRISP using it the way they would like to, or the way I think they should be? No, I don't think they are. I'm not pointing any fingers. But so you guys have a lot of power. You guys meaning the all-payer and CMS looking over your shoulder. So that would be another example.
Yeah, and I think to the point, tying again together the work of the data and infrastructure work group, we had just talked about modifying the definition on page 6. I love this document. Tying together that new definition, we were first talking about discharges with a PCP or primary care or principal provider identified, and that data and infrastructure group decided to have that measure be the number of discharges where there was a notice to the principal provider. So that kind of brings in the CRISP measure and the discussion and the physician side, a little bit of that. And if we're already monitoring it, it doesn't mean any more reporting burden. So an idea.
I just had one question. The overuse index, how many variables did you say was in that?
I think, Albert, do you happen to know? I think it's 100, but it's in process. It's on your website, actually.
Okay.
You can download it.
And is it primarily diagnostic tests, or is it a conglomeration?
Conglomeration. And by the way, two other things that are astounding about where we are now. Did you know every time that you go to the pharmacy in real time for every patient in the state of Maryland, it is known instantaneously out in the data system. CRISP actually has access to it, but can't use it for a variety of reasons. The opportunities to use that for all types of measurement. And now that 90% of all Marylanders have an insurance card for their pharmacy. And did you know 70% of all the laboratory work that any of us get are in a computer 30 seconds after the computer finishes it? That's never happened before. And those are there's some legal issues and other issues. But again, I encourage you. There are not a lot of places that we can really talk about the full denominator for a variety of reasons until we get all the pay. Well, another is the electronic data interchange. Some of you know better than I what percentage of a claim is known to that big network instantaneously. But in theory, that could be used for population health as well. Hospitals don't have access to it. But if you add the payers there, okay, so it's really legal and conceptual issues. The payers, the pharmaceutical pharmacies of Maryland, and the labs of Maryland, it is already built. And so by you pulling some of these things in, and I know the infrastructure committee is some of them are listening in too. So those are some real examples, and Trish, I look forward to looking at the list and being more specific.
Jonathan, slide 24, going back to your schematic about the M-PHIN, is you didn't define here whether information from the EMRs is only from hospitals, because this is your concept for the global budget hospital payment system, or whether you envision this coming.
I jumped over it. You know what my answer would be. It's foolish only to look at the hospitals. And granted, your purview, I get a little confused, but you can't do population health with only the hospitals, even the OPD. And I know about the ACO facet of it. Now it's true, it's a little bit easier when you have a healthcare system that has all the primary care and specialty care. But unfortunately, one day we will need to cut across to have population health and interoperability. We will need all sources. We at Johns Hopkins are the #2 client of EPIC. EPIC, as some of you know, is the largest EMR, particularly for the big systems. Mercy, Hopkins, Maryland, and Kaiser. 50% of all patients in Maryland are on one EMR, for example. And I'm talking about the hospital and most of the ambulatory. And I've been talking to them, and they're very excited. The head of EPIC is a closet public health person, and she's, for example, would be interested in collaborating possibly. It is true that the CRISP has not had great successes yet. I'm not blaming them. Most HIEs haven't in the ambulatory side, but that's one of the most of the EMR vendors would be very open to collaborating. I don't know what's in your purview and what isn't, but certainly for the big systems that have the ambulatory side in their system, the community health centers, which I believe you, yes, are involved in. As you know, many of them have been doing EMRs for a long time, and at least for their population, there might be models there too.
Well, and I think part of my question was, since you move the EMR data into CRISP and then a direct shot rate up to the health data warehouse, is how had you envisioned, pulling, because so many of the community-based providers, including the FQHC, have disparate systems, and there's only one set of data I know, at least among the FQHCs, where there's at least some continuity in how the data is structured in a data warehouse. How do you take all that data in and get it up into the...
It will be done. It can be done. Can it be done tomorrow? No. Are there challenges? Yes. Our ONC, the Federal HHS Office and National Coordinator, has been a huge leader in this, and they backed off for political reasons. Participating in HIE is not a meaningful use criteria. It should have been. but maybe it can be for you. I don't know. And I think one day it will happen. Will it be? Will it happen tomorrow? No, it will definitely happen and should happen. And every other country in the world has figured it out.
Yeah, and I agree with you that it will happen eventually. I personally feel that while we can be successful with the Medicare waiver to a certain extent with the data systems that we have now, but if we really are going to, I think someone said earlier, flip the paradigm, we need to be able to have more data interchange, because while Chris is doing a good job, I know you don't think it's doing all it can do.
Well, I think they're one of the 2 or 3 best in the country.
I mean, but we are getting we're getting the ENS data, we're getting the pharmacy data, and we're using it. We're using
Some
it
people
for
are.
drug interaction.
So you mean your organization?
Yeah, we've been doing it for a long time, so we've gotten better. But the ENS data on discharges, admits, and discharges is a little harder. The prescription stuff is real time, so the doc is in there, we get the interactions and all that stuff. That's easy to deal with. But the ENS stuff, now we get to the point where it's an actionable item. We don't have the resources to act. So yeah, the doc gets the ping that says their patients in the in the ER. But
by the way, data overload is a huge issue. Trying to have smart systems and predictive systems and algorithms will also be part of it. So the doc is only bothered when the odds are that she needs to know, that he needs to know. And so that's something else on our agenda. Other questions, Dan? I don't know what your timeline is. We're probably approaching it.
Is anyone on the phone who wants to jump in before we adjourn? Thank you so much.
So thank you for listening to me, and my email is on the back. I hope to come back again, and again, I mean what I say. You guys are doing a real public service. Thank you.
Thank you very much. Our work group meeting next meets on May 28th at 1.
Right. Thank you for including us. I think it was very helpful. Very helpful.
Thank you.
Thank you.
Thank you.
Well, kind of working in a vacuum.
Yeah.
Yeah.
And maybe that's how it'll evolve after July 1st.
Yeah.
Come together more integrated.
Mm-hmm. Yeah. No. Very, very helpful.